Hey guys, welcome to Dog Shala. So today we are going to discuss about a very interesting and very favorite topic to most of us, that is about diabetes. Diabetes mellitus. A question was given in NEET MDS 2023. So let's just dive into what is diabetes. I know you all know what is diabetes, but we'll just revise it and we'll also see the question that was given. So let's just go. So diabetes mellitus. So diabetes mellitus is nothing but it is a metabolic disease. Okay, it is a metabolic disease involving inappropriately elevated blood glucose levels. So it has several categories such as type 1 diabetes, type 2 diabetes, maturity onset diabetes of the young, which is MODI, and gestational diabetes, neonatal diabetes, and also secondary causes which leads to diabetes such as endocrinopathies like thyroid disorders and steroid use, long-term steroid use, etc. can also lead to formation of diabetes mellitus. So in this picture here, you can see the uh, uh, way how the difference between the type 1 and type 2 diabetes. So a healthy pancreas, this is pancreas. The healthy pancreas produces insulin, which helps in providing insulin receptor, which helps in binding of glucose to the insulin receptor in the cell. And this is what is the mechanism. When there is pancreatic failure to produce the insulin enzyme, then it leads to type 1 diabetes as the glucose does not bind to the insulin receptor. When there is insulin production, but the insulin receptor is not found. Okay, then the glucose is produced by the pancreas, but the glucose fails to respond to insulin properly. That is, there is decrease in production of insulin, which leads to not formation of insulin receptor. So we'll see everything in detail. I'm just giving a gist here. Okay, so let's just see everything in detail now. Okay, coming to the etiology and pathogenesis of type 1 diabetes. Type 1 diabetes, where the, now only I've told you, right? Type 1 diabetes, where the pancreas fails to produce insulin. Insulin is zero. So the etiology and pathogenesis behind it is profound insulin deficiency leading to replacement therapy is essential in this type of diabetes. T cell mediated autoimmune disease leading to beta cell destruction. Clinical symptoms appear after 80 to 90% of beta cell loss. Pathology shows insulitis with destruction of beta cells while glucagon secreting cells remain intact. Genetic predisposition accounts for about one third of susceptibility with 35% concordance in monozygotic twins. Then HLA haplotypes DR3 and DR4 are on chromosome 6 increase susceptibility. So these haplotypes, if they are present on chromosome 6, they increase susceptibility for type 1 diabetes. Then associated with other autoimmune disorders such as thyroid disease, celiac disease, Addison's disease, pernicious anemia, and vitiligo. Okay. Then coming to the environmental factors that are associated with the etiology and pathogenesis of type 1 are geographic or seasonal variations. Some geographic and seasonal variations do suggest their influence, and implicated viral infections. Viral infections, if the patient is having a viral infection or has been affected with a viral infection such as mumps, Coxsackie B4, retroviruses or congenital rubella or cytomegalovirus or Epstein-Barr virus, then they can predispose to a type 1 diabetes mellitus. Then dietary factors like nitrosamines, which are found in smoked meats and coffee, is proposed as a potential diabetogenic toxins. Okay. Then bovine serum albumin from cow's milk is also linked to diabetes 1, type 1, and reduced childhood exposure to microorganisms may increase autoimmune disease susceptibility, which might lead to formation of any other autoimmune disorder that might predispose to formation of diabetes mellitus. Okay. Then coming to metabolic disturbances. Metabolic disturbances When insulin can no longer maintain the glucose control, then we see the type 1 diabetes mellitus. We all know that. Then hyperglycemia may be toxic to the remaining beta cells, leading to rapid insulin deficiency. When the insulin is not working, then there is the glucose is excess in the blood, then that leads to hyperglycemia, which is in turn toxic to the beta cells of the pancreas, which leads to rapid insulin deficiency. Then resulting metabolic defects include glycosuria and dehydration, secondary hyperaldosteronism, and unrestrained lipolysis and proteolysis causing weight loss, increased gluconeogenesis, and ketogenesis. Ketoacidosis may occur when ketone body production metabolism is exceeding the metabolism. Then, secondary hyperaldosteronism leads to potassium loss. Patients presents with hyperglycemic symptoms, weight loss, and potential ketoacidosis. Okay. Then, type 2. So type 2 is diagnosed after excluding other causes of hyperglycemia. The other causes of hyperglycemia are excluded, then only we will diagnose type 2, including type 1 diabetes mellitus should also be excluded. So if the patient retains some insulin secretion but have insulin resistance. So in patients having insulin resistance followed by impaired pancreatic beta cell function. Insulin is produced okay normally, but the patient is having insulin resistance, which is followed by impaired pancreatic beta cell function, resulting in relative insulin deficiency. So why is he having an insulin resistance? It might be tied to any other metabolic syndrome, may lead to the insulin resistance or any heart disease, and complex causes such as adipose tissue worsens and inactivity, like patient doesn't exercise or anything. So if they are having zero activity, then that also leads to insulin resistance. So in such patients, exercise can help them. Then pancreatic beta cell failure. Where is it seen pancreatic beta cell failure? In early type 2 diabetes, 50% of beta cell function is lost. Like almost 50% of beta cell function is lost in early stages of type 2 itself. Then amyloid deposits form and genetic factors also play a role in pancreatic beta cell failure in these patients. Okay. Then coming to the causes of type 2 diabetes, the environmental factors include overeating, obesity, inactivity are the risk, mainly affects middle aged people and elderly. Type 1 is seen in young people also, young age people also, they are seen in with type 1, but type 2 mostly prevalent in middle aged and elderly, and onset of symptoms is rather bit slow. And metabolic disturbances include like low insulin, which is needed to suppress the fat breakdown. Low insulin helps in fat metabolism, but since there is low insulin, the fat breakdown suppresses. Then weight loss is rare and ketoacidosis, and symptoms develop very slowly. So causes of type 2 diabetes as seen in this picture: high BP, pancreatic diseases, obesity, increased age, genetic predisposition, stress, sedentary lifestyle, unhealthy food, and certain kind of medications. Okay. Then coming to the pancreatic disease, what kind of pancreatic disease? Like I told you, apart from type 1, type 2, it is also the other types of diabetes mellitus are also there. So if there is pancreatic diseases such as pancreatitis, hemochromatosis, or cystic fibrosis, they can lead to diabetes mellitus. Excess insulin antagonists such as in acromegaly, Cushing syndrome, and thyrotoxicosis can lead to diabetes mellitus. Then genetic beta cell defects, example, MODY. And genetic insulin action defects, genetic factors affecting insulin response, and drug-induced diabetes, example, usage of corticosteroids, thiazides, and phenytoin for long periods of time, and diabetes in genetic syndromes such as Down syndrome, and DIDMOA. Okay. So these are the associated factors which help in producing diabetes mellitus. Then investigations, what we have to do, blood sugar investigation is done, and blood urine investigation is also done in urine investigation is also done in diabetes mellitus. So let's just have a look into those investigations also one by one clearly. Then urine testing, the glucose urine is test using urine dipsticks. Glycosuria needs blood test, right? Ketones are found during fasting, exercise, and vomiting or high fat diet. You can find ketones in urine. Then protein, to check for protein, standard dipsticks are there. They detect more than 300 milligrams per liter. And microalbuminuria requires specific sticks or lab analysis. Okay, standard dipsticks only detect when the protein in the urine is more than 300 milligram per liter. Then blood testing, glucose is tested in lab, tests are reliable, capillary blood for portable meters, and ketones are monitored through blood by beta hydroxybutyrate, which is useful in illness or hyperglycemia. And glycated hemoglobin or HbA1c. It is an accurate measure of glucose control over weeks. If the patient is suffering from several months with the same symptoms and he has been detected positive in the blood test before, we can use to confirm, but he has been irregular with the treatment or anything of that kind, we can confirm the diagnosis of diabetes mellitus yet again with HbA1c measurement. Okay. Then fasting blood plasma glucose test, patient has to have a overnight fasting, at least 8 hours of fasting. After 8 hours of fasting in the morning, the patient is asked to give a blood test to check for the fasting glucose. So it is most reliable when it is done in the morning. It is done in the morning only. So if glucose level is 100 to 125, a form of impaired fasting glucose is seen. It is a form of pre-diabetes. Okay. It is likely the patient is likely to develop type 2 diabetes, but he doesn't have it yet. 99 and below are non-diabetic. 100 to 125 pre-diabetes, and above 126 it is diabetes, and you can confirm it by recalling the patient for yet another test on the other day to just be sure with that. Then oral glucose tolerance test, OGTT. Oral glucose tolerance test, actually it is more sensitive than that of the fasting plasma glucose as per this, but it is less convenient to administer. That's why we don't use it normally in the clinics. But nowadays we are using it to check for patients who are pregnant or who can't come like frequently. So then here also patient needs to fast 8 hours before the test, and the plasma glucose is measured immediately before and 2 hours after he drinks 75 grams of glucose dissolved in water. So first of all, during fasting we have to test, and also after we have to give the patient of 75 grams of glucose dissolved in water, make him sit for 2 hours, and then again we have to test for glucose levels in the blood. If it is between 140 and 199 milligram per deciliters 2 hours after drinking the liquid, then he is pre-diabetic to type 2 diabetes. And 2 hours after it, if he is having 200 milligram per deciliter or above, then it is a confirmed diabetes is confirmed. Then so here you can see the table. 139 on below normal, 140 to 199 pre-diabetes, 200 and above is diabetes. Okay, then gestational diabetes is also diagnosed on plasma glucose values measured during OGTT. So gestational diabetes is diabetes seen in pregnant women. Then blood sugar levels are checked 4 times during the test. For them, blood sugar levels are checked 4 times. Blood sugar levels are above normal at least twice during the test. Then patient is having gestational diabetes. So you can see the table here. So during fasting, 95 or higher. After 1 hour, 180 or higher. After 2 hours, 155. After 3 hours, 140 or higher. So at least two of the findings should be in this range to confirm gestational diabetes of the patient. Then random plasma glucose test. This is a very favorite test of everyone. So before surgeries, like also we give for random plasma glucose test. So if it is of 200 milligram per deciliter or more, plus the patient is having increased urination, polyuria, polydipsia, and unexplained weight loss, and other symptoms such as fatigue, blood vision, or increased hunger, that is polyphagia, and sores and or wounds which did not heal, then only we can confirm that patient is having diabetes. If you have a value of above 200 or something like that, we normally do not do any invasive procedure on that day. But to confirm the diagnosis of diabetes, we have to take we make the patient take the test of fasting glucose and uh, postprandial glucose the next day, and then only we can confirm the diagnosis of diabetes. Okay, and the patient should present with these symptoms also. Then glycated hemoglobin or the HbA1c. HbA1c is a newer guidelines. They are used as a screening tool or diagnostic test for pre-diabetes or diabetes. It is mostly used to confirm pre-diabetes or diabetes. So it is a very powerful tool. It helps in diagnosing the pre-diabetic condition mostly. So once we find out the values like abnormal values in the fasting glucose or postprandial glucose test, then we can advise for HbA1c for the patient. So it will assess the degree of glycemic control, which is with the degree of glycemic control like for longer periods, like for at least 3 months. Okay. So enzymatic glycosylation of HbA1c occurs 90 to 120 days after this. So therefore, it gives an estimate of diabetic control and compliance of 3 to 4 months. And advantages: no dietary preparation of fasting is required in this test. And HbA1c of 5.7 to 6.4% is consistent with pre-diabetes and marks a time when it can be reversed by lifestyle changes. Then if it is 6.5% or higher, it is consistent with diabetes. It might not be accurate in the second or third trimester of pregnancy or in certain types of anemia. Okay. Then clinical features. Clinical features of type 1 diabetes are, weight loss, excessive thirst, excessive urine, okay, fatigue, blood vision, pruritus valva or balanitis, nausea, hyperphagia, irritability, poor concentration, and headache. Then type 2 diabetes may be asymptomatic because symptoms develop slowly. Chronic fatigue or malaise may be associated, increased susceptibility to infection, skin infection in uncontrolled cases, and pancreatic disease history such as insulin deficiency. Then management: type 1 diabetes, urgent insulin therapy is advised. Type 2, first of all, we'll advise dietary and lifestyle advice and followed by oral antibiotic drugs if necessary. In any comorbidities are associated like hypertension or anything, the patient has to be treated for those comorbidities also. Then the question which was asked in the previous NEET MDS exam was, a 32-year-old obese woman has polyphagia, polydipsia, polyuria. She was on irregular diabetic treatment for 3 months. Her FPS, that is fasting blood sugar, shows 140 milligram per deciliter, and postprandial blood sugar shows 240 milligram per deciliter. Which of the following investigation would ideally suit for patient follow-up? So for 3 months, she was on irregular diabetic treatment. So, uh, she was in irregular diabetic treatment. That means she was already diagnosed with diabetes for 3 months, and her latest results also show she is in the range of pre-diabetes here and here. So the third investigation which we can suggest is HbA1c. If this is also coming positive, then the patient is diabetic. Okay. So if you like our video, do like, subscribe to our YouTube channel, and you can also follow us on Instagram handle at Docshala for dental content and at Docshala Medical for medical content. You can also find us on Telegram. Thank you and have a nice day.